For those of you joining us online, I say the same thing. Welcome to our bariatric educational seminar. This will be the first of many. The purpose of this seminar is primarily to disseminate information that will be necessary so you, as our patients, will be able to make informed decisions regarding your care. Bariatric surgery is a big field and it is a big deal. There will be a significant lifestyle change for most of our patients over the next several years, and we hope that it will be permanent. So the more information you have, the more informed you'll be, and the better the outcome will be. So I'm very proud of our program. By the way, my name is Dr. Keneth Hall. I'm a board-certified surgeon. I've been in this space for approximately 12 years. I've been fortunate enough to have conducted several thousand surgeries, and with a very well-learned, well-distinguished, very professional staff, we're able to launch our comprehensive bariatric surgery center here at Rome Health last year. And since then, we have done almost 200 cases. So that's an impressive accomplishment for such a small program, and it's a testament to our institution. And that also tells you that we're very committed to what we do. But what qualifies me to talk to you in the first place? First of all, I'm extremely passionate about bariatric surgery and about taking care of patients who are morbidly obese or obese. And as such, I've aligned myself with all the necessary training necessary so we as a group and as a team can attain the success that what we had. You know, as a kid, I wanted to be first a neurosurgeon, and then over time that changed. And then I said I wanted to become a plastic surgeon, and halfway through residency, through my training, I met a guy who turned out to have a significant impact on my life. And he became my mentor. And when I first met him, I realized that we were doing a very difficult case. And I found out that that particular patient, I drove several hundred miles from South Carolina, slept in her car, just so this particular surgeon could operate on her. And I said, wow, and it was a bariatric patient. I said to myself, I wanted to be that person. I really wanted to see why. And then over the years, I started to do those surgeries. And what got me was the amazing transformation that patients would have. You take a patient that has 6, 7, 8, 9 different medical problems: diabetes, hypertension, high cholesterol, sleep apnea. Some of them couldn't even walk. And in 6 months, there'd be an amazing transformation. So that really got me as a resident. But most importantly, it's the after effect. In my estimation and in my training, bariatric surgery is one of the only surgeries I see where you operate on one person, but you impact so many lives. The husband and the wife go home, they change their diet, they change the way they eat, and all of a sudden, an entire community begins to change and to transform their life. And that is the reason why I'm here. And that's what qualifies me to talk to you. Not because I love surgery, but because I'm passionate about what we do, and I'm invested in your success. Let the show go on. All right, so we're going to talk about how to make a lifestyle change, and I'll be your pilot. I'll guide you through it. But most importantly, what is obesity? What are the associated challenges that people may face who are morbidly obese? What is the cost, be it financial or otherwise? What are the surgical options? Most people are here today, they want to know, number one, am I a candidate for surgery? And number two, what procedure may work best for me? What are the next steps? Doc, I am here. How do we move forward? And I'll go over a few cases. We'll talk about some of our patients that have gone through the process. In the past, I've had them actually come to the seminar so they can actually talk to you, and that's something that we'll look into in the future. All right, stick with me for a little bit. I promise I won't keep you too long. So obesity. Basically, obesity is a condition in which there's an unhealthy accumulation of fats in the tissues, in the cells, under your skin, around your kidneys, around your heart, etc., in such a way that it negatively affects the way you live, the way you function. Okay? We have been fighting with the American Medical Association for many, many years, but in 2013, they finally agreed that obesity is in fact a disease, just like any other problem. And we hope what that means is people will be more sensitive to understand that it's not just because that person ate too much. And you'll see later on it is multifactorial, which means that there are many different reasons why people are obese, and we shouldn't judge them, because sometimes it goes way deeper. Now, it's a large percentage of Americans are obese, most of which are females, and that number is expanding significantly. By 2050, half the population will be morbidly obese if we're continuing at this trend. So I mentioned before, what are the causes? It turns out there's an interplay between genetics, behavior, and the environment. Now, what do I mean by genetics? Oftentimes I'll have patients that may come to me. Sometimes they're sisters, sometimes they're relatives. One may be obese, the other is not. And they eat the same way sometimes. They exercise the same way. Genes are funny, and they're inherited in different ways. So you may have somebody that may have a gene that may be passed on through several generations. One person may get it, the other person may not. We see it all the time. So this is typically the contribution from your parents, parents, and it can go much further back. Your behavior is basically what you do to contribute to your particular circumstance. A lot of my patients, for example, are bus drivers, so they have a sedentary lifestyle. They don't exercise as much. So because of that, that may be one of the reasons that they may be obese. And the environment is just the place in which you live. Here in upstate New York, there's an access to fast food. Every block, there's a McDonald's or a KFC or some other fast food. And over time, that can have a significant harmful effect on your health. Now, and these are other factors. They're all interplay with the three topics I mentioned before. And again, you are the individual that's definitively and definitely affected based on your particular circumstance. So let's take a history lesson. In the 1950s, this was size of, what do you call it, Happy Meal? Happy Meal or Burger King. And the point is, portion sizes have increased significantly over time. And what that means is, it's much harder for you to burn that excess calorie. You know, I was preparing for a talk several years ago. I was invited to speak at this event. And what I did was, I was trying to do an experiment. I ran on the treadmill for about an hour, and I didn't look. I didn't want to see. I hid my face, and I ran inclined. And after about an hour, I actually thought I felt so tired and out of breath. So I was very proud of myself. By then, I thought I did approximately 1,000 calories. After all that, I was only like 300 calories. Now, it took me an hour to do that, but how long would it take me to eat a slice of bagel? A couple of seconds maybe, right? A minute. So the point is, it's way easier to gain calories that way. So portion sizes have increased significantly, and with that, that has contributed significantly to the epidemic that we have. It's so common, nobody's even making a big deal about it. Look at what happened here. Heart attack grill. You have some of these in California, Los Angeles, for example. A patient actually died, and no one realized because they thought it was a joke. This is a big deal, and no one's taking it seriously enough. What we'll teach you to do is to attain a healthy, normal weight. We'll get you there if you're not there. And once you get there, you'll realize that it's a balancing act, right? It depends on how much you take in and how much energy you burn. And we'll help you figure out how to use that scale. But why is this so important? Why do we care so much about obesity? And as I said before, there's a direct relationship with obesity and many of these comorbid conditions, particularly diabetes. I would say 90% of my patients are diabetic. And if they're not, they're pre-diabetic or they don't know it yet. Wait until I get that blood work and they'll be surprised. So diabetes is directly associated with morbid obesity, as well as most of these here. But these are what I normally see on a daily basis. And this is why we send you for all these tests. Not because we want to torture you, but want to make sure that you're optimized so we can address these prior to surgery. And luckily, most of these will be cured, not treated, cured with surgery. And by the way, surgery is one of the only means by which you can actually attain a cure. Most of the other processes are treatment. You can treat a disease with a medication. It's a treatment, but to attain cure, at least for morbid obesity, this is one of the only ways by which you can cure these. So obesity is a multisystem disease. It affects your heart, your liver, your kidney. You know, most of my patients have fatty liver disease. That's why I do a liver biopsy. Patients ask me all the time, why do you biopsy the liver? Because sometimes there's a small chance that you can have cirrhosis or fatty liver disease. The metabolic syndrome, that's also very common. And you can tell by the distribution of the patient's fat. Heartburn is very, very common. Pancreatitis, breast cancers, etc., colon cancers, all these are much more increased in people who are morbidly obese. A lot of my patients have GYN and infertility issues, and after surgery they become much, much more fertile, particularly those with PCOS, or polycystic ovarian disease or syndrome. So what are the challenges? Again, why do we care? There's significant amount of challenges and changes that occur in the patients who are morbidly obese that can make life very difficult. And as a consequence of that, many of my patients face prejudices on a daily basis. We want to overcome a lot of these obstacles. I had a patient who told me he had such a hard time going through the turnstile. I had others who told me they couldn't go to the movies because they were so scared of getting out and moving around. Some can't climb upstairs. Some of patients come to see me in a wheelchair and they have a hard time. But I'm comforted by the fact that I know as a physician that at the end of the road, for most of these patients, there will be a significantly improvement in their overall quality of life. So for that reason, we're very encouraged by our weight loss surgery. I had a patient many years ago who told me, every time I put the slide up, he would say, "Doc, I felt like I was that guy." He couldn't ride in a plane. He was a pastor. I did his surgery. He was about 500 pounds. And the last time I spoke, he was like 160 pounds. So we lost almost 2 body weights over a period of time. So that has been one of the driving facts why bariatric surgery is so important, because it does change your life. Now, what is BMI? It's called the body mass index. But in short, what I want you to understand is it's a measure of how heavy you are for your height. So the higher your BMI, the more likely it is that you'll have a cardiac event, a problem, a diabetes, etc. And for insurance purposes, typically you can get bariatric surgery coverage with a BMI of 35 and above. So most times, if you're 35 to 39.9, the insurance companies are looking for a medical problem, okay, such as diabetes or hypertension, etc., which is why we send you for these tests. If it's 40 and above, most people can get coverage for bariatric surgery. And again, I keep saying the same thing. Why do we care? As your BMI increases, your life expectancy decreases significantly. In fact, on average, most of our patients will gain approximately 10 years on their life by having bariatric surgery. What is the cost? Now, it's sometimes financial, but there's other emotional and psychological costs associated with being morbidly obese. There are many different programs. Every day there's a different diet, there's a different menu that comes out, but in all, it can be very, very expensive for the average person. And secondly, compliance is a problem. You may subscribe to them and it may work for a while. After a while, it becomes difficult. Cost of clothing is more expensive, and it's also difficult to get. Now, as your BMI increases, I mentioned before, hospitalizations increase, wound care increase, pharmacy visits increase, lab works increase, and over time this can be exponential. Now, about 5 years ago, and this is the most recent slide I have, however, it cost the average American who's morbidly obese approximately $18,000 extra just in medical care. I suspect it's more like 25,000 these days. And that's an average looking at the overall cost of healthcare relating to patients who are morbidly obese. And that's expected to increase over time. Now we have a diagnosis of morbid obesity. Where do we go from here and what can be done? Now again, there are several different diets, and for most people, lifestyle changes, okay? That's the first line therapy. Most people will be able to do diet and exercises, etc. Some people may be amenable or may benefit from medications, but in general, for the most part, long-term solutions for most people who are already morbidly obese lie with surgery, unfortunately. And fortunately at the same time, because at the end of the day, most of these people are able to live normal lives. Now, what are the surgical options that we have available today at Rome Health? The two most commonly done surgeries by me are the Roux-en-Y gastric bypass, which has been around for many, many years, as well as the sleeve gastrectomy. And we'll talk about those. I have also been doing a lot of revisions and conversions. Now, what do I mean by a revision? We have had patients over the years who have had one particular weight loss surgery or another, such as a lap band or a sleeve gastrectomy or even a gastric bypass. And sometimes, for some reason or another, maybe there's a technical error on the part of the surgeon or that stomach might have stretched, etc. But every now and again, I have to revise them or convert them. For example, from a sleeve, I may go from a sleeve gastrectomy to a gastric bypass, or may go from a band to a bypass or band to a sleeve. And every now and again, I have to revise the sleeve and revise the pouch and make it smaller. So it all depends on what was the primary operation. Who qualifies for surgery? Patients with a BMI of 35 and above. We said 35 to 39.9, typically they're looking for a medical problem. Once it gets to 40, most people are covered automatically. Obviously, you have to be healthy enough to undergo an operation. Bariatric surgeons take more risk than the average person. Most surgeons will not operate on somebody who's morbidly obese. They'll send them to us first, or they'll tell the patient, go lose 50 pounds before your knee surgery or your hip surgery or your back surgery, because it's too much of a high risk. Yet still bariatric surgeons do this routinely all the time. Nonetheless, you need to be optimized. So most of our patients need to see a cardiologist or a regular medical doctor, as well as a pulmonologist, etc., depending on what the constellation of medical problems are. You cannot be an alcoholic. In fact, we have to document that you have abstained from alcohol for an extended period of time. We don't do active smokers because there's an extremely high risk of complications such as a perforation, bleeding, death, leaks, etc. with smokers, because smokers typically don't heal as well. Most importantly, you have to be dedicated. We need to know for sure that this is what you want to do and that you're willing to make the commitment. And we're here to help you. We're like a family. We get to know each person very well, and you'll interact with different members of staff. And this is for the sole purpose that we can best suit you and that we can best take care of you. As it relates to which procedure we choose, it's typically related to your medical problems, your overall health. I had a guy, for example, he had a mechanical heart valve and he was very sick. So the gastric bypass typically is more involved and takes a little bit longer, and I will show you a video. So for that particular patient, I did a sleeve gastrectomy, and I can do that sometimes in 25 to 35 minutes. So it depends. Some people, if their BMI is larger and there are no other reasons that we can't do it, I may offer a gastric bypass surgery. So it all depends on what's happening. People with certain collagen vascular diseases, people with lupus, people with Crohn's disease, or any type of condition that may require a large amount of steroids typically are not good candidates for gastric bypass. So that's the reason why we sit down and have a conversation and see what is the best procedure for you. This is just a schematic of the human digestive system. It's good to get an idea of what's happening so you can understand the next video that's going to come. Typically, that long tube from the top is the, doesn't project well, it's the esophagus. When you eat, food goes from the back of the throat to the esophagus, comes all the way down into the stomach, which is right here. And from the stomach, it goes into the small intestine, get processed, and then into the large intestines before all the liquid is absorbed in the colon, particularly the water. This is just for historic means. The lap band has been around for a long time, but we no longer see a lot of the procedures except for when clients come to me to have this taken out. Again, the most common procedure we do these days are the sleeve gastrectomy, not just here, but primarily throughout the entire country. Just because in concept it's so simple. Basically, you have a stomach and you divide that stomach. You take approximately 70 to 80% of that stomach out. It's called a restrictive procedure. It means that it limits the amount of food that you can eat. But the beauty about it is that the absorption is normal. What you eat is essentially what you get. The gastric bypass has been around the longest. It's the most complicated procedure to understand, but in general, it is the most effective for the most part. And typically, we'll target patients with higher BMI, typically BMI 50 and above. However, under certain circumstances, a patient may qualify for a gastric bypass. Again, we have to be more careful with certain things such as heartburn or H. pylori, which is a bacteria that can cause ulcerations, and the patient selection have to be carefully looked at. The complication rates are slightly higher. Nonetheless, this is a very safe operation. It's been around from the 50s, and patients do extremely well. Okay, so let's look at what you'd expect after bariatric surgery. Typically, most of the comorbidities will be completely cured. If you look at cardiac function, for example, I remember having a patient on the heart transplant list. She had an ejection fraction, I believe, of 10. And in a very short period of time, we were able to get her off the transplant list, and she actually did well and never needed any more heart surgeries. High cholesterol, hypertension, sleep apnea, most of these are cured with weight loss surgery. What are the complications? There are few. If you look at all bariatric surgery, serious complications are less than 4%, which is significantly better compared to other surgeries. Now, how do we look at bariatric surgery? How do we put everything together? Basically, the first line of therapy against or treatment against morbid obesity is lifestyle modification. Typically, it's exercise, it's dieting, physical activity, etc. When that fails, typically you go one level up, which is medical management or medications, etc. And there are all different classes of medication these days. And lastly, at the top is bariatric surgery. It's not for everyone, but typically it is the most effective treatment there is for morbid obesity. In fact, there was a New York Times article about 2 years ago which looked at the series The Biggest Loser. And what they found was 100% of patients who have lost weight during that first episode, they all gained the weight back, and most of them gained more. What does that mean? Once you are morbidly obese, the chance that you will lose the weight and keep it off on your own is almost zero. Not zero, but it's almost zero, because all the issues are still there. Obesity, you can't change. The genetics, etc., you can't change, and all the selective pressures of life are still there. But how do we choose the right operation? I touched on this before. Your age, medical problems, etc. Ultimately, it's a mutual decision amongst us, and we'll talk about that. It's important that you set expectations. People lose at different rates, and again, it depends on the surgery that you have. Will give us an idea if we know exactly what your metabolism is, approximately how much you'll lose. Most people will lose weight up to 18 months. And we find in general, people with gastric bypass will lose a little bit more. What are the next steps? Well, you have done the most important thing, which is to attend the seminar. This is one of the best ways to get information about bariatric surgery. But you have taken the first step. You'll have to schedule a meeting. We'll do the process such as verifying your insurance information, etc. But we have a full staff which will help you do all of this stuff. Everyone will need an upper endoscopy. You need a GI consult to make sure that there's no problems with your intestines or with your stomach. Everyone needs an ultrasound to make sure that's also taken care of. You see a nutritionist. We all need a psych evaluation just to make sure that you're completely competent and you understand what it is that you're about to undergo. Ultimately, support is very important, and it's important that you have somebody to help you and guide you through this process. It can seem daunting, but again, we have a good team. We're here to support you and to help you along the way. Why us? Why Rome? Well, we have an extreme diverse experience in bariatric surgery. I in particular have been doing it for many years, and I've adopted all types of technology and platforms in the process. I've spoke nationally and internationally, but despite all that, the most important thing is that we have a caring professional staff that's here to take care of you. Now, multiple people have undergone bariatric surgery in the past. These are some famous people that you may or may not know, most of which have undergone bariatric surgery. Let's look at some before and after pictures. This particular patient wanted to jump out of a plane. Initially, it wasn't feasible, probably wasn't safe. After a few short months, she was able to attain her dreams. Same person, believe it or not. Dramatic change. This particular patient was approximately very close to 500 pounds. In about a year, he was under 200 pounds. And he's actually one of the billboard type persons for Lifetime Fitness in Long Island. This is one of our patients, had surgery last year. Last year, as you can see, there is a dramatic change. So yes, it's important to look good and to feel good, but it's also the quality of life that you're going to have by not carrying around all that excess fat. Your heart will thank you. So another of our patients. It's not just a diet, it's not just a surgery, it is a lifetime change. Be prepared, as I said over and over. It is not easy. It is not an easy way out. It's a smart way. I see patients all the time and they say to me, Doc, I want to try this first, I want to try that first. And I'm always here to support people, whatever you want to do. But my job is to provide education as well as the staff, so you'll know when to give you all the tools necessary to be successful. I want to thank you very much for your attention, and we do appreciate the support that you have given us and the team of Rome Health, and we hope that we'll continue to grow as a program, and as we continue to serve the community, we'll ask for all your help. So thank you very much for listening, and at this time I will take your questions. Question in the back? No? Okay. And the question? Sure.
I was going to say, how long does it take from like the start to like until you have surgery? Like what is it 6 months? Is it, just curious.
So the question was how long is the process from your first scene at the initial consultation to the time of surgery? And that typically depends on, number one, the insurance company, and two, the patient. Some insurance companies will get you in as soon as you finish all the requirements, which is typically some of the stuff I mentioned before, like seeing your PCP, having an upper endoscopy, having abdominal ultrasound, seeing a psychologist, and if you have cardiac issues, obviously seeing your cardiologist. So, these days, because of COVID, it's become increasingly difficult to get appointments, We have been having problems with gastroenterology at some centers, but we can definitely get you in, especially if you see our team. There's a team of people that we work with, and they understand the urgency to get people in, so we can certainly help you. But in general, it's 3 to 6 months. Most of the private payers will take about 6 months, while Medicaid and Medicare is typically 3 months, or again, typically as soon as you can get the stuff done. Any other questions for me?
What is the recovery process, or how long are you in the hospital after surgery? I know it would probably be different for each individual, but.
Very good. The question is, what is the recovery process like, and how long do you stay in the hospital? So the recovery process is actually quite shocking. Most of our patients are home in less than 24 hours. Typically, the surgery is done in the morning, and by the morning or afternoon, and by the next morning, I would say 99% of our patients are ready to go. And again, the thing I find very fascinating is this is obviously major surgery, even though it's done minimally invasively, but pain doesn't seem to be a huge problem at all. In fact, almost, I'd say, less than 1% of our patients will leave with a narcotic. So these people are just leaving with Tylenol or gabapentin or something like that, and they're leaving with very little pain, very little to no nausea, and they do very well. So the recovery process is actually very good. And in fact, some people may actually overdo it. We have had patients who have gone to work 3 days after that, and we can't control it, but we tell them not to. But in general, most people can go back to work in 2 weeks, especially if it's not heavy lifting or anything like that, anything that's exhaustive. But it depends. Everyone recovers differently. It depends your age, your functional status, etc. All those will factor in. Oh, that's an excellent question. Is there any questions online from the live stream? Is there questions on the live stream?
No, didn't get any on this one, no.
What's the oldest patient you've ever had?
What's the oldest? They're asking me all good questions. The question was, what is the oldest patients I've ever had? I believe it was 81. And the question is, people may ask me, why do you do an 81-year-old? That's a good question. And again, it depends on the functional status. You have some 81-year-old that look really good, and they just need a little help. Their heart's good, and I suspect that they're going to live at least 10 years. Why not make it the best 10 years of your life? Why give up on that 81-year-old? So it all depends. So the age itself is not an independent factor. I've done as young as 14. A 14-year-old is the youngest I've ever done, and we're a comprehensive bariatric surgery, which means we can do any age and any type of procedure, but 14 is the youngest, and I believe I've done 81 is the oldest. But that person's functional status was much better. You have to be able to walk, you have to be able to get around, otherwise the complications are higher. If you have a major surgery like this and you're not able to get around, you may have a pulmonary embolism or a clot, etc. So people do much better. I've also had a patient with a muscular problem, in fact, they haven't walked for 8 years, and that person wanted weight loss surgery. And the challenge was, I told her, unfortunately, I can't do your surgery unless you're able to walk, and that was a challenge. We arranged physical therapy, and she was extremely motivated. And within 6 months, she was able to take a few steps, and by, I believe it was 9 months, she was able to walk. We did her surgery, and she did absolutely amazing. So weight loss makes everything better. I can't think of anything that gets worse with weight loss surgery.
So we got one online here. Any special medications or anything after the fact that a patient needs to know about when going through this?
The question is, any special medications that they'll need to know about? Typically, no. It all depends on their overall problems. There's some people that have certain medical conditions, and we may need to adjust the doses. For example, if we're doing a Roux-en-Y gastric bypass, at times we may have to adjust the dose depending on what that medication is. We have people with seizure disorders, and sometimes we have to adjust that. We have some psych medications that we sometimes have to adjust. But our hope is, for the psych medications, most patients are able to get off it. A lot of my patients are able to get off the depression and the anxiety medication after weight loss surgery. So as it relates to diabetes and hypertension, again, a good 90% of our patients are able to get off those medications. In fact, I would say, Stephanie, correct me if I'm wrong, I would say 95% of our patients are off their diabetic meds within weeks. Every now and again, we have an outlier that may take a month or two, but typically most patients are off, meaning that they are cured. So medication management and will help the primary care physicians manage most of these medications for the first several months until they're attained steady state, is what I like to say. It means most people are doing well on their own, but will definitely help, especially with the diabetic medications, because sometimes they have to be adjusted. Any other questions? Question in the back?
After you have the surgery, like what does the diet look like and what does your meal plan look like?
So the question is, after you have the surgery, what does your diet look like? What does a diet plan look like? Well, the beauty is we'll go through dieting throughout the entire workup process, so it won't be a surprise to you. So you'll know what your diet's going to be. Immediately after surgery, patients go on a clear liquid diet. It's a clear liquid, high protein, and most of the diets are going to be based on a higher protein for the first month or so, 1 to 5 weeks. So every week right after surgery, you'll increase. So for example, clear to puree, soft, etc., until you get to regular diet. I would tell most people to stay away from beef, at least wait a little bit. It may take a little bit longer based on the consistency. In general, and for certain vegetables and starches, it's better to wait at least 3 months, just because it's much more difficult and it may cause problems. You have a much smaller pouch now, or stomach, and sometimes some of these green leafy vegetables could get stuck, in theory. So we typically say wait in most of these rougher plants and fruits and vegetables for about 3 months. In general, by 3 months, most people can go back to eating whatever they were eating before. The healthy stuff, that is. We hope that you're not going to go through this and put us through all this to go back to gain the weight back. And luckily, we can say most of our patients are doing very, 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 very well. And the single most important reason why patients do well is compliance, follow up. Follow up, that is the most important thing. We never discharge our patients like some practices. We keep you forever because we believe this is a lifelong process, and that's when you may need us the most. Most primary care physicians don't understand bariatric surgery, so they're not equipped to completely manage, and if there's a complication or issue, we want to know about it. So if you're failing for any reason, come to us first so we can get to the root of the problem after the first 5 pounds, after the first 10 pounds, before it gets to 100. We can help. Excellent questions.
What if it does, what if you do eat something and it gets stuck, like you say? What do you do?
Well, like anything else, go to the emergency room. So the question is, if you're eating and something gets stuck, what do you do? We have taken every precaution to do that. In the 200 patients that we have done, that has happened once. And again, it's primarily because we have talked about it and we told them to be careful, especially with pills. We tell people anything bigger than an M&M to crush. Some programs don't do that, but I have seen where it has caused a lot of problem in the middle of the night. Patients have to go to the emergency room because stuff gets stuck from the swelling after surgery. So anything bigger than an M&M in terms of medications, we encourage you to crush. We encourage you to eat slowly. But if it does get stuck, go to the emergency room, and typically we have to have a gastroenterologist or remove that foreign body. So not fun, but it can be done. But it's extremely rare, extremely rare. You had a second question? I know you were saying, okay, good. Any other questions, comments, or concerns? Stephanie, anything that they should be asking that they're not asking? Well, let me say this one thing, because people ask me all the time. This is the first time I've spoken at a place like this and nobody asks, what happened to the loose skin? Nobody wants to know? It magically vanished. No. No, but typically, yes, I've always had that question. So typically, again, depends on your age and your level of activity. Some people will have laxity and some people will have loose skin. And that's something that we can typically take care of for the most part. I'm able to fight with the insurance companies, then I win most of the time. You know, we can't guarantee it, but we can certainly get that off. In this grand scheme of things, you are investing in yourself and in your own health. And skin removal is secondary. The most important thing is to live a healthier, happier quality of life. But we can certainly help with skin removals, and we've been doing them routinely. In fact, we've done one today. We did the last week. We're doing them very routinely now, having the skin removed, particularly from the abdominal wall. Insurance companies typically don't pay for it anywhere else because it's considered cosmetic, but from the abdominal wall, it can cause a lot of discomfort, psychological discomfort, rashes, itching, etc. It doesn't happen all the time, but when it does, we can certainly help. Thank you very much for your attention, and we'll look forward to seeing you at your next educational seminar.